In the previous slide, we have seen the various stages of COPD. The treatment, of course, will depend on the staging. Whatever may be the stage, whether mild, moderate, severe or very severe, active reduction of risk factors, influenza vaccination are a must for all the stages. Adding short-acting bronchodilator as and when needed depending on the dyspnea, depending on the symptoms, is essential. If the FEV1 by FVC ratio is less than 0.7 and if the FEV1 alone is more than 80% predicted, which is stage 1, this treatment is adequate. In patients who have got moderate disease or stage 2, we need to add regular treatment with one or more of the long-acting bronchodilators. These are called the LABAs, and of course pulmonary rehabilitation has to be thought of and should be encouraged. And the addition of long-acting bronchodilators may be on a regular basis or as and when needed basis. If the disease is severe, meaning that the FEV1 by FVC ratio is less than 7% and the FEV1 alone is less than 50% predicted, then of course it is in stage 3 and you need to add inhaled glucocorticoids if repeated exacerbations occur in such a patient. In very severe disease, adding a long-term oxygen therapy, LTOT, long-term oxygen therapy for chronic respiratory insufficiency, and of course surgical treatments like lung resection or lung transplantation are essential for people with severe COPD. So, to summarize, in stage 1 disease, risk modification, influenza vaccination, short-acting bronchodilators. In stage 2, same will continue, risk modification and short-acting bronchodilators as and when needed basis, plus long-acting bronchodilators, either the LABAs or the LAMAs, antimuscarinic agents or the beta agonists have to be added. In stage 3, addition of inhaled glucocorticoids is a must. And then in stage 4, very severe disease, long-term oxygen therapy, home oxygen therapy and surgical techniques have to be considered. As we know, there are two types of mechanisms by which the bronchodilation can occur. One is to use beta agonists or the beta agonists, as we commonly call the salbutamol, the salmeterol. The onset of action of salbutamol is very short and then quick acting, and whereas salmeterol takes around 20 minutes to act. Duration of action of salbutamol is 4 to 6 hours, so much so we need to repeat the salbutamol doses over a period of over the day, or 2 to 3 times or sometimes 4 times. Salmeterol has got 12 hours action, so BID dosing is adequate. The selectivity for beta 2 receptors when compared to the beta 1 receptors of the heart, so without cardio acceleration producing bronchodilation, the selectivity for salbutamol is 1:375:1, whereas the highly selective is salmeterol. When we go to the antimuscarinic agents, which are the acetylcholine blockers, and these are the ipratropium and tiotropium. Ipratropium, the onset of action is 20 minutes, tiotropium, the onset of action is 40 minutes, whereas the duration of action is 4 to 8 hours, so ipratropium needs to be given at least twice or thrice, whereas tiotropium 24 plus hours, it is a once a day drug. Whereas ipratropium acts on all the 3 muscarinic receptors, whereas tiotropium is specific to more for M1 and M3 and not to M2. With the result, the M1 and M3 receptors are very important for bronchodilation property compared to M2 receptors. So, tiotropium is more specific to the bronchial musculature. So, either we can use a long-acting beta agonist or a short-acting beta agonist depending on the scenario and the situation. Like that, anticholinergics also, short-acting ipratropium or long-acting tiotropium we can use, or a combination of both these types of drugs is sometimes warranted. What are the goals of management of COPD? To prevent the disease progression, because it is a progressive disease, and to relieve the symptoms, of course, and to improve the exercise tolerance, improve the health status of the individual as a whole, and prevent the metabolic and other systemic effects of COPD, to prevent and treat the complications, to prevent and treat the exacerbations, and of course in the long run to reduce the mortality due to COPD. The management of COPD revolves around bronchodilator medications. They are central to the symptomatic management of COPD. They are given as on need basis or on a regular basis to prevent or reduce the symptoms depending on the staging of the disease, as we have seen in the previous slide. The principal bronchodilator treatments are beta-2 agonist salbutamol group, and then the anticholinergics, the ipratropium group. Theophylline or a combination of these can be tried in refractory cases, but usually theophylline are not that effective and useful in COPD. A combination of beta-2 agonists and anticholinergics can be tried. Please remember, in the management of COPD, none of the existing medications for COPD, the long-acting bronchodilators, the long-acting antimuscarinic agents, the long-acting beta-2 agonists, they have shown to modify the long-term decline in lung function, including the long-acting including the inhaled corticosteroids. So the decline of the lung function is the hallmark of the disease. But none of these medications decrease the decline in the lung function or reduce the mortality. But then what do they do? They improve the symptomatic status. They make the patient better. They make the patient live comfortably. Therefore, pharmacotherapy for COPD is used only to decrease the symptoms and the complications, and not to halt the disease or reduce mortality. But stopping smoking will halt the COPD. This is the only intervention which is known to stop the progression of the disease. So it's important for all of us to underline this message to all the patients and see that we make them quit the smoking. The use of systemic steroids in COPD is contraindicated. This is because it increases the risk of infection, it increases the osteoporosis, it increases the metabolic complications of steroids. Already COPD is a systemic disease. Inhalation treatment is the best. Salmeterol, the long-acting LABA, is the first choice. Ipratropium is the second choice. Salbutamol, of course, for short bursts for acute symptoms. Inhaled steroids when the symptoms are not controlled with a combination of salmeterol and ipratropium. Combination inhalers are more beneficial. Oral beta-2 agonists like syrups and tablets can be used in patients who are not relieved with inhaled steroids. Theophylline, the role is very debatable, and if at all we use long-acting preparation and not the short-acting preparations. No injectable theophylline at all. Methylxanthines in injection form, they are cardiotoxic and may end up in fatality. Anti-leukotriene agents like montelukast are of no use in COPD. Oxygen therapy for exacerbations and respiratory failure should be considered in all patients of COPD. This diagram summarizes the synergistic bronchodilation. The lung is served by the sympathetic as well as the parasympathetic. The parasympathetic nerve endings secrete acetylcholine, and the effect of acetylcholine is to constrict the bronchi, whereas sympathetic secrete the sympathomimetic amines. The effect of them is bronchodilation. So, in order to achieve bronchodilation, we can either use a bronchodilator, which is a sympathomimetic drug like the beta-2 agonist. Beta-1 receptors are in the heart, so we should not use one which stimulates the beta-1 receptors of the sympathetic nerve endings, but the beta-2 receptors of the bronchial smooth muscle, thereby reduce the sort of bronchial smooth muscle tone and relax the bronchi. Whereas we can also achieve some amount of bronchodilation by preventing the constrictor effect of acetylcholine by using anticholinergic agents. So tiotropium and ipratropium are the drugs which are anticholinergics or antimuscarinic in their effect, M1 and M3 receptors, whereas here the LABAs and the SABAs are the ones which are having the action on the beta receptors. So in order to achieve bronchodilation, we can use LABA or SABA to reduce to increase the sympathetic drive there and produce bronchodilation. We can use the anticholinergics like antimuscarinic agents like ipratropium, tiotropium to reduce the cholinergic tone and increase the bronchodilation. What are anticholinergic drugs? Cholinergic drive is the main bronchoconstrictor pathway. Anticholinergics act by reducing the resting bronchomotor tone. They act on the three muscarinic receptors, the M1, M2 and the M3. Ipratropium, oxytropium onset is slower than the beta agonist. They act on M1, M2 and M3 receptors. Sustained bronchodilation up to 8 hours or more, they are effective. They have influence on sleep quality in COPD. Ipratropium optimal dose is 80 micrograms as inhaler. Tiotropium selective to M1 and M3 receptors. It is long acting once a day and 40 micrograms is the dose of tiotropium. The methylxanthines, also called the theophylline group of drugs, they are assumed to relax the airway smooth muscle. At therapeutic concentrations, no direct action on the bronchial smooth muscle can be seen. Toxicity mainly due to drug interactions. The therapeutic window or safety window is very narrow and the therapeutic index is very low. Need to monitor the blood levels frequently. Adverse effects on the liver and in the elderly. Their use is at best questionable. Never use injectable forms of theophylline. In many countries, these drugs are banned. Sustained preparations has some add-on value in the treatment of chronic asthma and chronic COPD. Inhaled corticosteroids in stage 1 and stage 2 COPD, they have no role to play. Only when the patient is having severe or very severe COPD, ICS come into picture. Betamethasone, budesonide, fluticasone. Betamethasone very short acting, budesonide intermediate acting, fluticasone long acting. Inhaled steroids are preferred and they reduce the number of episodes of exacerbations. To be used in stage 3 and stage 4 of COPD. They are useful in short bursts in acute exacerbations. In people with significant asthma component, they are found very useful as preventers or controllers. No role for long-acting steroid injections or long-acting or oral steroid preparations in COPD. What else can we do to improve the prognosis and to reduce the disease progression and then improve the symptomatic problems of the COPD patients? Pneumococcal vaccine can be given in addition to influenza vaccine. Early initiation of oxygen therapy shown to increase the survival. Prolonged use of inhaled steroids, long acting better, 2 weeks duration. Alpha-1 antitrypsin is available as Prolestin or Arelast and it's in patients who have deficiency of alpha-1 antitrypsin. The protease, these are available. This is called the protease augmentation therapy. Antibiotics in short bursts for exacerbations and acetylcysteine is shown to be useful and it is available now in the nebulizing form. Immunomodulators are under trial, calcium and vitamin D supplementation to control the osteoporosis. So what should not be used? No antitussives, cough suppressant is dangerous and not beneficial at all. Mucolytics role is questionable and several trials have not shown any benefit. No prophylactic antibiotics please. Only when there is acute exacerbation with symptoms of bacterial infection, then only we need to use antibiotics. No long-term antibiotics, no systemic steroids, no narcotics, no antihistaminics, no breathing exercises in a COPD patient, no withholding of the benefits of oxygen. Early oxygen therapy is important. What are the future developments of COPD? COPD is going to increase. The mortality is going to become a big problem. Diagnostic facilities also are increasing. Quitting smoking is a must. Industrial pollution increases, so also the COPD occurrence and COPD related problems. Newer drugs will appear. New drug delivery systems are appearing. Oxygen therapy utility will be increasing. Emphasis should be on early diagnosis, effective anti-smoking services. COPD will be primary care issue by the GP other than by the specialist. new drug development for COPD per se can occur, and it might be the answer. Tiotropium takes a center stage now, and new M1 and M3 blockers are in the line. PDE4 inhibitors for bronchodilation are being tried, and rofimilast, and these types of PDE4 inhibitors are newer drugs, cilomilast and rofimilast. Drugs to decrease the neutrophilic inflammation, mediator antagonists which decrease the inflammation. All these are future developments in the field of COPD. What are the take-home messages on COPD? COPD is no more a specialist concern. It is the general practitioner's disease. It should be treated by the general practitioners, diagnosed and suspected by the general practitioner. It is alarmingly increasing and it is preventable. Remember, COPD patient, don't write them off. It is preventable and treatable. Please differentiate asthma and COPD because the main treatment of asthma is inhaled corticosteroids. The main treatment of COPD is long-acting bronchodilators. The main treatment of asthma is to prevent the inflammation and then control the acute episodes. The main treatment of COPD is smoking cessation and early initiation of oxygen therapy. Use spirometry, peak flow meter just as we use ECG and X-ray. Do not embark on Theophylline betnosol intravenous for all breathlessness. These are outdated modalities of treatment. Don't use Theophylline as far as possible. If at all use Theophylline as an add-on drug, use long-acting preparations. Inhalation therapy is the best. Drug delivery choices are your option and individualized depending on the patient. Do not spare anybody from early oxygen therapy. And finally, motivate smokers to quit smoking. We see a patient with cough, we see a patient with breathlessness and sputum. Could it be COPD? The patient himself can have a checklist. Do you know what COPD is? This chronic lung disease is a major cause of illness. Many people have it and yet they do not know it. If you answer these questions, it will help you find out if you could have COPD. Do you cough several times in most days? Yes or no? Do you bring up phlegm or mucus most days? Yes or no? Do you get out of breath more easily than others of your age? Yes or no? Are you older than 40 years? Are you a current smoker or ex-smoker? If the answer to these questions, 3 or more of these questions is yes, you please encourage the patient to see the doctor, his physician, and he or she will have to investigate and see whether the patient has got COPD and should have a simple breathing test called the spirometry. And if COPD is found early, there are steps you can take to prevent further lung damage and make you feel better. If you are a smoker, right now start and pick up a date to quit it and achieve a smoking free life. Take time to think about your lungs, learn about COPD. Every one of us should take a pledge to stop smoking this devil, this menace to the mankind. By stopping smoking, not only we prevent COPD and lung cancer, we prevent multi-system deterioration of health. There is no organ system that is spared due to smoking's ill effects. So all of us know that. Only thing is we should have the willingness to encourage and urge the patients, urge the smokers to stop smoking. So yours faithfully, that means I urge you, a little time spent talking to your patients is really a great investment for their health. This may make all the difference between a happy, healthy life and pulmonary invalidity. If we do not communicate and make them understand that inhalation therapy is the best treatment, quitting smoking is the best answer for COPD, and continuation of inhaled corticosteroids to prevent chronic asthma and remodeling of airways, we will be producing pulmonary invalids. We don't want that to happen. We want all our patients of asthma and COPD to live a very healthy and happy life. For that, we have a very great responsibility, and the onus is on us to see that we urge the patients to be on inhaled medications and to quit smoking. A little time spent is lifetime happiness. Look at all these young children, look at all these elderly persons who are invalids due to pulmonary COPD one day. Now when they started using inhaled medications, inhaled bronchodilators, inhaled corticosteroids, long-term inhaled steroids, and they have quit smoking. COPD and asthma will be a thing of the past, and they will live very happy, healthy life. Thank you all very much, and with this I am closing the CME, and I request you to visit the website and then give me any feedback on this presentation, and also if you have any questions you can write to me over the mail, or you can now discuss at the end of the presentation. Thank you very much.